I'm going to spend a little time talking about the goals of prolapse repair and some anatomy, but hopefully a little bit more practical surgical anatomy tips. So I think before we do any sort of a prolapse repair, we actually have to know what is normal anatomy. And honestly, I've been in this field for about 18 years, and I'm really not sure I completely understand normal anatomy. But this was a study done by Steve Swift in South Carolina in the United States, where they took almost 500 women who had not a single pelvic floor symptom, who were just coming in for the routine pap smeared regular gynecologic care. And so, here's the uterus, here's the vagina, that classic POP-Q diagram. About 6% of those women were stage 1, 43 or stage 0, 43% were stage 1, 48% of women were stage 2, and 3% were stage 3. So in other words, over half of normal women presenting for GYN care are stage 3 or 4 prolapse. So what's the relationship between anatomy and symptoms? So if we know prolapse to the level of the hymen is probably normal in women after they've had children and they go through menopause, when does it become a problem? And I think that's when we need to connect anatomy with symptoms. Numerous studies have now shown that the symptom that most commonly kind of correlates or is associated with abnormal POP-Q findings is a symptom of a vaginal bulge. Pressure, low back pain, bowel and urinary symptoms, those things may or may not go along with having prolapse, but the only one that's truly associated with consistently with prolapse is a vaginal bulge. We also know that patients become symptomatic when the bulge hits the hymen and really when it starts to go a little bit outside the hymen. So if you see a patient, we probably all see those patients sent into the office where they've seen their general gynecologist or their primary care physician who get sent in for a cystocele or told that their bladder's fallen. My first question when the patient comes in that way is, if the doctor didn't tell you you had a problem, would you know it? And if the answer is no, I can usually examine them and go on to reassure them that there's nothing that we need to do other than observation, because that finding is probably normal. And so surgery for prolapse is less than +1 or 1 centimeter outside the hymen is probably unnecessary. So quick review of anatomy. This is a side view. You can see the sacrum, rectum, vagina, uterus up here, bladder. When we normally talk about the normal supports of the pelvic floor muscles, the 3 primary things that we talk about are the connective tissue supports, which are primarily, we know now, the uterosacral ligaments with some support from the cardinal ligaments, the pelvic floor muscles or the levator ani, and then the upper 2/3 of the vagina probably get horizontal supports from the arcus tendineus fascia pelvis, and then you can see the vagina here's the levators. The vagina actually is parallel to the levators. It isn't going straight up and down this way, it's horizontal. So again, just a little bit more detailed picture of the support. Here we're looking into the pelvis. The pubic bone is here. You can see the rectum back here, cervix where the uterus has been amputated, urethra here. And when you think about the support of the upper vagina, we think about the cardinal and uterosacral ligaments that come back and insert into the cervix and then fan back to the sacrum to hold up the upper vagina. And then the lower 2/3 of the vagina are by these lateral supports. So you have the arcus tendineus fascia pelvis here that extends from the pubic bone back to the ischial spine to provide support for that anterior vaginal wall. So to me, this picture sort of helps illustrate when I'm trying to teach my fellows and teach my residents that you really can't have loss of the apex without having loss of the anterior vaginal wall. They run together. The distal anterior vaginal wall inserts into the apex. So probably if you have enough prolapse in one compartment that is bothersome, you should be checking the other compartments as well. So I think that isolated anterior defects, if you even go to try to do any sort of design comparative effectiveness trials or clinical research, and you're trying to design a trial to randomize women to just repairing the anterior vaginal wall, that's almost impossible to do outside of someone who's actually had a prior apical suspension procedure, because anterior defects alone are very rare. Even going back to 1997, there was a hospital discharge survey, which pretty much comprises a national sample of women in the United States who had surgery and then got discharged. And isolated anterior repairs or cystocele or paravaginal repairs, only about 18% of prolapse, counted only for about 18% of prolapse surgery in the United States. I would bet if we did that study today, it would even be lower than that. So what is the relationship between the anterior vaginal wall and the apex? There's been a couple studies that have kind of mathematically modeled this. This is one that we did in our institution many years ago, where we just took 350 women who had at least stage 2 or greater prolapse. All of them had POP-Q data, and we literally just plotted the most prolapse portion of the apex, or POP-Q point C, against the most prolapse portion of the anterior vaginal wall, or prolapse point BA. And you can see you pretty much have a linear relationship between the apex and the vagina. And then when we created the best regression or modeling equation, we found that if the anterior vaginal wall was at the hymen, the apex was always within 4 centimeters of that. So if you're going back to correct someone's anterior vaginal wall, you certainly don't want to leave their apex, which normally would be at -10, at -4. So this is a study done at the University of Michigan by John Delancey's team, where instead of just using physical exam and POP-Q points, they did dynamic MRIs and looked at the position of the cervical os on MRI and plotted that against the most caudal point of the actual bladder itself on MRI. And again, you found the same linear relationship. As the bladder comes down, the apex is coming down as well. So when they did a regression to try to find out what segments or components of the vagina, the total vaginal length, the genital hiatus, the anterior vaginal wall, the posterior vaginal wall, were most associated with anterior vaginal wall prolapse, they found about 77% of anterior vaginal wall prolapse, or a cystocele in this case, because they were actually looking at the bladder itself on MRI, can be explained by both the apex and the total vaginal length. Which also stands to reason then if you simply, on your surgical repair, pull the apex back up and put that in its proper space, most of your cystocele is going to go away. So kind of in summary, I think the important clinical implications for anatomy, particularly of the apex and the anterior vaginal wall, are that I think we all now believe that the apical support is probably the dominant factor in most prolapse, and certainly of anterior vaginal wall support. So if the anterior vaginal wall is coming down, even if you see that and you haven't picked up on the apex, you need to check for the apex, whether you stand the patient, but do something to really feel the full extent of their apex. We also know from numerous series now that if you surgically correct the apex, most of the time that corrects the anterior vaginal wall prolapse, and you don't need to do any concomitant anterior vaginal wall repairs or paravaginal repairs. That's certainly true when you're approaching the repair abdominally, either through an open or a laparoscopic or robotic sacrocolpopexy. A little bit less clear on vaginal suspensions or native tissue suspensions. And like the necessity for concomitant anterior repairs at the time of vaginal prolapse surgery is a little bit less clear than it is for abdominal. So how does the posterior compartment fare? This was a study where they took 149 women who were undergoing open abdominal sacrocolpopexy, where the mesh was placed anterior and posteriorly. They looked at preoperative POP-Qs and 1 year postoperative POP-Qs. And if you look at the anterior vaginal wall, just by correcting the apex, improved. The posterior vaginal wall, which was about 1 centimeter outside the hymen in the majority of women, actually improved just by pulling up the apex. So I think that shows that even a distal posterior vaginal wall prolapse in most women will improve significantly just by supporting the apex. Even the genital hiatus decreased in size by about 1 centimeter. So another group essentially showed the same thing, where they took 258 women who were undergoing abdominal sacrocolpopexy with or without posterior repair, and found no difference in the anterior apical or posterior POP-Q postoperatively at either 3 months or 1 year. So essentially, if you got a posterior repair, you didn't fare any better than if you didn't get a posterior repair. The CARE study, which was a national study done in the United States, where women who were undergoing open abdominal sacrocolpopexy got randomized to Birch or no Birch. One of the ancillary outcomes of that study was to look at posterior compartment symptoms. At 1 year, some of the patients got a posterior repair, some of them did not. When you compared posterior compartment symptoms and anatomy at 1 year in those patients, the only differences were the patients who got a concomitant posterior repair had more pain with defecation and slightly higher rates of fecal incontinence. More recently, in the Journal of Female Pelvic Medicine and Reconstructive Surgery, they looked at 5-year outcomes on those patients. Those data pretty much hold true, with the exception that the patients who got a concomitant repair, posterior repair at their initial colpopexy, were more likely to be reoperated on in the posterior compartment in that 5-year follow-up period. There can be many hypotheses as to why that is. My personal belief is the reason that if you got one, you're more likely to be reoperated on later, is probably surgeon threshold for fixing that compartment, because most of the other preoperative symptoms were pretty similar. So we've talked a lot about the connective tissue supports, and what about the muscles? So a couple questions that I think come to mind are, do women with levator ani defects have higher operative failure rates than those without? I mean, all the surgeries that we do are just designed to connect fascial defects or compensate for structural defects. We don't really do any talk about the levator ani. Is there a way that we should be fixing the muscles? And should we address those surgically? And, just a caveat, I'm not sure we have the answer to this yet, but I think it's the next thing on the horizon for us to figure out. So these are some MRI images from John Delancey, where here you can see the pubic bone, you can see the urethra, the vagina here, and then you can see the pubococcygeus muscles, and this is all in a normal nulliparous woman. And you can see this muscle extends all the way back up to the pubic bone. And now you take a woman who had had 1 vaginal delivery, didn't necessarily have symptomatic prolapse, but you can see her pubococcygeus muscle no longer is attached to the pubic symphysis. So essentially this muscle here should be attached up here. So she clearly has a detachment or some sort of loss of her pubococcygeus muscle or levator ani muscle. I think the question of the hour is, how does that relate to future development of prolapse? And if this patient has prolapse, let's say her cardinal ligaments are detached, and let's say both of them have a connective tissue defect, and this patient still has an intact levator ani, is her outcome of surgery likely to be better, worse, or the same as this patient? And I don't think any of us really know the answer to that question yet. So this was a case control study where they took MRIs and diagnosed him as having a levator ani defect or not. And they had a normal group with no control group that didn't have any prolapse anatomically by POP-Q exam or symptoms. And then they had a prolapse group who had both symptoms and POP-Q point, POP-Q stage 2 or greater. And you can see 55% of the women in the prolapse group actually had evidence of levator ani defects compared to only about 15% of the normal group. So there's definitely some component of levator ani dysfunction that's going along with these women with prolapse. So in conclusion, I think that as we think about the goals anatomically for surgical repair of prolapse, we need to understand each defect, and we need to really be carefully to identify the anterior vaginal segment, the apical segment, and the posterior vaginal segment. I think we often get kind of tricked in the office. We examine women supine and dorsal lithotomy. Gravity is going to always make the anterior vaginal wall come down first. So I really encourage, if there's some question, to stand the patient and really have her bear down and let gravity kind of display that apex for you. I think it's rare to have isolated anterior posterior vaginal wall defects without also having a concomitant apical defect beyond the normal range. Remember, if the anterior vaginal or posterior vaginal wall is at the hymen and the patient doesn't have symptoms of a bulge, that's probably normal. And if you're only going to fix one compartment, so if you can only, they said you only have one hammer, you got to pick something to fix, make sure it's the apex.